health needs of the population, and commissioning appropriate services across all of the different organisations, such as primary care, community care, mental health, and the acute hospitals. So our role is to look after that. CCG is a £1.5 billion business in Dorset, and the health service collectively covers around 20,000 people, providing services. Today I'm just going to talk about a particular aspect of what we're doing in healthcare, and that's focusing on the research, innovation, digital, and how we bring some of those things together. So to do that, what I'm going to do now is I'm just going to share a presentation with you, and I'll just walk you through the story about creating a living lab. So just bear with me a second while that loads up. John, can I just check with you that you can see that okay?
Yep, can see all of that.
Lovely. Well, it's just the logo. Thanks, though.
Yeah.
So we're going to talk about the living lab, and I thought I'd set the context for that, which is about looking at Dorset and how the health service, local authorities, voluntary sector, third sector, and charities all work together to create an integrated care system. There are about 800,000 people that live in Dorset, and there's a wide range of health and care needs, and it's different depending on your age, your stage of life, whether you've got any underlying conditions, and whether you live in a small rural community or you live in the centre of the conurbation. All needs are different across the whole of the county of Dorset, and the role of the integrated care system is to work together as a collaboration to bring the best possible services for the people in the local communities. And we do that through organisations which you're I'm sure you're all very familiar with, which are the acute hospitals, and we have one in Dorset County which serves the west of Dorset and the Dorset Council area, and then we have two across in the east of the county which have merged this month to become the University Hospitals Dorset, but they're the hospitals in Poole and Bournemouth. We've then got 13 hospitals across the communities, and then approximately 85 GP practices, and collectively they deliver the sort of premises-based, and then we've got community-based teams who go into the homes. And the integrated care system is looking after the population, which is the purple icon in the centre, and then we do it through a range of things from the acute hospital right the way down to people at home, and we also support prevention and helping people stay fit and healthy. So I just wanted to set that as our context for today, and then focus specifically on two of the collaboration groups that exist to support the integrated care system. So one of the groups is Research Active Dorset, and they're the research leads and the innovation leads for all of the NHS organisations. So that's for the hospitals, for primary care with GPs, and for community care and mental health. It's the local authority research leads for social care research, and it's the organisations which support research that support within Dorset and in the broader across to our neighbours across into Hampshire. So that includes Bournemouth University, it includes the Chiropractic College in Bournemouth, which is a university, specialist university in its own right. It also includes linking through into Southampton. And then we've got another number of other NHS bodies, which is the National Institute of Health Research, which is the group that currently supporting the COVID vaccine work. And we've got something called the Applied Research Collaboration, which brings together some of the leading research in health. So that's the Research Active Dorset group. And then the Dorset Informatics group are the clinicians who are driving forward some of the digital work, and it's the technical people across a range of expertise who work with them to create solutions for better health and care. And I'll touch on some of those later. But they're the two groups I just want to focus on. The core of the focus for all of this, whether it's a Dorset integrated care system or the two collaboration groups I've just talked about, which is the Research Active Dorset and the Dorset Informatics Group, are focused absolutely on patient benefit. So it's all focus around the people who live in Dorset and what their care needs are. And the reason why I'm giving you what seems like a very obvious statement is that the focus around the living lab concept, which I will take you through in this presentation, absolutely helps accelerate benefits that can be delivered by both the health and the social care system in Dorset. And there's some really good evidence for that. The national and international evidence shows that if people are involved in as participants in clinical trials, or if they're involved in parts of research and development for new technologies, a number of things happen. One is they get often immediate personal benefit from being involved. The second thing they get is helping other people from the research that's being done. And the third thing they get is a broader awareness of the different approaches to health and care, and are better able to both understand what's available and take part in what's available. So all of the evidence shows that the more you have your communities involved in research, and the more people directly involved in research, the better it is for both the individual and the communities. And then overall, it's providing a massive benefit to the NHS and the services that we can deliver overall. So there really is a lot of very good reasons for being part of research and innovation as an individual. There's also real benefits for our staff. What tends to happen as you do more research, you start to be able to give the staff that we have working in the system different areas of interest to work on. So they can have their substantive role, delivery, working in A&E, or working on the wards, or working as a GP out in primary care, or working as a nurse out in the community, or a healthcare assistant, or a social worker, or a physiotherapist. They can have all of those core roles that they are really passionate about, but they can also start to research some of the areas that support the roles that they're doing, and also help them broaden their horizons into other roles that they may not have considered working. And that really does help across boundaries between organizations. It helps cross boundaries in within an organization. And if we look at one of our hospitals with approximately 4,000 members of staff, there's a huge community of people, and research helps them better network, better navigate services, and be more engaged in everything that's going on. And as a direct result of that, the patients that they providing care to benefit. So there's some real benefits for being a member of staff. And what we've seen, with the research we're already doing in Dorset, that there's a lot of positive engagement, and some of it recognised nationally as being some of the best research in that particular specialist fields, which is obviously really good news. If we then look at the areas of focus and the sort of things that we're currently doing in Dorset, we're looking at a number of areas, and we've got a number of areas that we're not currently looking at that we'd really like to get involved. And particularly if we look over the border into Hampshire and see what's happening in Southampton, we can see there are some great things happening there that if we were to engage more in Dorset, we would be able to realise some of the benefits I've already talked about. One of the areas is precision medicine, and this is about being able to understand an individual's down at the basic chemical layer. So what is their chemistry, and being able to provide them with different solutions absolutely based on their individual chemistry. And this helps reduce risk. This helps targeting particular care packages of care to the individual, and it lets us know what works well and what doesn't work well without having to prescribe it and then ask you see what happened. We've got a much better idea from the very start. Now that kind of work is currently happening in Southampton, and other work related to that is starting to look at how we can use the genetic makeup of individuals to also help us understand what we could do from a pharmaceutical and drugs point of view, and how we could help be much more precise in what we deliver. Excuse me. What this means is that if we were doing this in Dorset, we'd be able to do several things all at once. We'd be able to broaden our understanding of the population and its needs. We'd be able to closely look at how the body of science doing, and this is not worth pursuing. So there's a massive opportunity for us to get involved in that. The next thing, which is really important for us, is we've got a number of areas that of concern in our current system. So we've got an average aging population, which is older than the average in other parts of England. We've also seen that there's an increase in diabetes. We've seen there's challenges around cardiovascular disease. There's also issues around cancers and a number of other areas that we'd like to look at. So by focusing some of our effort on research in those spaces, we'd be able to do a better job for the people who live in the county. So our opportunity is, how do we bring all this together? And as part of that, we've been thinking about a living laboratory concept, which allows research to happen in the community. And if we could do that in the community, we could do a number of things to benefit everybody who lives in Dorset. So let's have a look at the sort of things that we could have in this vision of change. The first thing we could do is we could improve health and well-being, and we could improve it in a way where we're actively engaging people in the development of what they need. The second thing we could do is accelerate innovation and grow research by bringing together all of the people across the county who work in their different organisations and bringing them into one place. The third thing we can do is we can help our staff discover new ways of working, new technology, and new digital solutions. And then finally, we can bring a sector together which allows us to do inward investment into Dorset. And we've got some big companies who are really interested if Dorset was doing this work. But we're not starting from a standing start. We've got a number of things in place already. We've got digital research happening. We've got a research group. We've got a care record, which integrates all our care system records. We've got a vaccine hub we've just launched this week. We've got external partners. We've got some medical technology companies in the county. And we've got agreement with Bournemouth University to work collaboratively on research. So we've got lots of the building blocks to help us build a new way of working. So that's where the living laboratory concept comes from. This is about how do we create centres in Dorset which are community based, which allows us to bring together innovation and research, to allow us to do co-design with people, and to create an anchor point for inward investment for life science companies who want to work more closely with the population to help understand needs, and then to help the NHS look at the services that we should provide right across the system. Now, the connection of all of those things together, this living laboratory would bring together data science, research, and innovation. Let's look at what that might look like. So here's an artist's impression of the sort of thing that we could create, which would be a green environment with patients coming in and receiving services, whilst researchers are working with them to say what needs to be improved. And we can provide education for new students coming through, working with the university. We could create a medical school, and we could create a centre for research and development for technology and biotech companies who want to develop new products which are appropriate for our local community. So here's an example of what and the kind of thing we might want to look in as we look at in close up is creating a community where we are all living and helping develop research and innovation at the same time. So that was a brief run through of the concept of that we're trying to achieve, how it links into the what we all as residents of Dorset and the sort of things we might need, and bring together NHS, local authorities, and the universities to make sure that we've got a joined up way of looking at it. So, John, I'll wrap up there and happy to open up for questions.
Thanks, Phil. Thank you very much. It's really interesting. I know I was really pleased when you said that you could come and talk to us about it, because it's I didn't know about it in any great detail particularly, but it was really good, the work that I've been doing in the last kind of 18 months at the ICS level across the piece with RAD and workforce and digital. So it's really exciting stuff. Do you think if there are any questions, by the way, folks, please pop something in the chat and we can bring them up. One of the things that occurs to me is I know my own family's journey with cancer, and the fact that we've been able to, when you were talking about the genetics and that personalised care piece, actually being able to understand what the impact might be on the next generation, if there was an impact on the next generation, and those pieces as well. Does it bring about some questions around ethics? I guess there's a bit, I think about with genomics, for instance, if it's more likely that I have a particular trait towards an illness from my genetic makeup. I'm aware there's some concern around what that might mean for insurance, and how do you think we would manage to keep that stuff safe? Is there a role for government here about legislating at that point?
I think there's several things, John, in what you just said. The first thing is the NHS, in the way it does research, it absolutely protects the patient's information. So it's not being done in a way which the information will be shared with other organisations. It's absolutely about managing the confidentiality. And for every patient who takes part of research, the confidentiality will be explained, and everybody will sign up individuals. So there's not a there's really good controls, I think, in place to help with that. The sort of things that, if I give some examples of where this type of research really helps, is there's some very rare diseases, and often people don't present with the symptoms to let the medic or the GP or a hospital doctor or nurse easily identify that they have one of these rare conditions. So the genomic medicine helps identify people who might have a likelihood. So it's not about saying, we know exactly what's going to happen to you. We know all the diseases you're going to get. We know when you're going to live or die, and we can pretty much give you a time slot for that. It's absolutely not about that. It's much more about saying, for this particular individual, there are some other tests that we might want to run that you wouldn't routinely run for everybody who presents with these types of symptoms. And a good example of that is people who have liver damage, and the work was done in Southampton, where it analysed lots of different types of data from the GP record and started to look at those people who were in the hospital with liver damage and the types of things they might have had before they got that far. And by doing that, it was possible to identify those people who were pre-liver damage and get in touch with them directly and say, we've noticed some things, some patterns in the information about you. And we think it would be worth having a look at these things, some of their markers. And if we find them positive, there are things we can really do to help, which will be much better for you and your outcomes now than it would be if you were sort of further down the line. And so that's an example of using this type of thinking to say, how can we help people? So there is the genetic bit which might help identify some of the rare disease potentially. There are some things that we can do about saying, for this particular individual, this different mix of pharmaceuticals will be a much better mix based on the chemistry which comes from the genetics. And then there's this other bit which says, but there's lots of other data about you. And we tend to work on what you present with and investigate that. Whereas really what we could do is do some pre-investigation behind the scenes and then start to give you a nudge to say, you really need to think about some things. Diabetes is a great example where there are lots of good ways of identifying pre-diabetes and helping people adjust their lifestyle typically before they then tip into diabetes and then need to deal with the consequences. And of course, at the worst stage, we're talking about leg amputations and other things. And it's a sort of thing which is, well, had I known earlier, I might have done something about it. And I think lots of what we're talking about is we think we can probably find a way to tell you earlier about some of this. But obviously, it still would, if you were the patient, John, it would still require you to then do your bit to help do this. I think the other bit as well is that if we can widen the number of people who get involved in research in its broader sense, then we've also got the opportunity to look at a wider range of variation. Because like all things, you tend to work in a small group of people and then you test at a small group and then you want to test wider and wider. But if we could get the Dorset population to say, we're pretty interested in signing up to be an active part of lots of different things that you might want to try, whether it's trying a new drug. So at the moment, we're encouraging people, for example, with the COVID vaccine trial, we're encouraging people to sign up to volunteer for that through the Fusion service. We're encouraging particularly men at the moment to sign up to donate blood plasma, which would have the antibodies into the virus, so we can use that for both research and for giving people plasma. And we're interested in people going forward to take a much more active role. So we're looking for can we get a positive engagement around that? And certainly for COVID at the moment, the Dorset population has been phenomenal in its response. We've had over 3,500 people sign up already to say they'd really like to take part in the trials. And we started the trials this week, and we'll be doing other trials down the line on other vaccines. So it's a great opportunity to start that right now. You can commit today to sign up to do that. And I hopefully we can maybe share the link with everybody afterwards who signed up on the for this session. I think the other bit though, just to come back to the first part of your question, is how we tie it in, how we avoid the ethics being undermined. And I've mentioned about patient and consent and how that's managed. But there's a much bigger society piece, which is way above what the NHS's role would be. We need to work with a society base to say the more we know about you, the more you'll know about yourself. How would it change your own behaviours, and how would you want to deal with that? And we find that at grief counselling, for example, if I just take that as a parallel. There are people who want to know, and there are people who don't want to know, and there are people who didn't want to know then do, and there are people who did want to know then don't. And there's all we're dealing with all human emotions wrapped up in all of this. So I think there's an ethics and a sort of scientific ethics, which I think there are good controls in place. But there's society type ethics and what's acceptable and what's not acceptable, and that can only be done really collectively. We'd have to work on that together.
Thank you. Fascinating. Got a couple of questions. John Sloper, I'm interested to know how you see the blending of health responses and research with community non-medical services being brought into this model, building a wider spectrum of interventions, especially the measurement of qualitative benefits as well as quantitative ones, or is this not the frame of this model?
So I think it is. I think it's all in scope. I think if I try and deal with this in two parts, the measure of success and then the engagement of the non-medical bit. So the conversation we've had with the local authorities, particularly about this, is if we start to look at air quality, air pollution, if we start to look at deprivation, if we start to look at those people being supported by a broader set of local authority services, those people who are being supported by voluntary sector or charity services, those people who have a certain economic profile, and then if you extend it out to behaviors around travel, propensity buying models, diet and shopping, sport and exercise, and you start to look at all of that data, and if we did it as layers of data, you can start to do some interpretation about the relatedness between the different data sets, and the living laboratory is absolutely all about that. And if I give you an example, Bournemouth Council have done a pilot where they've used drones to do overflying and infrared photography of heat patterns around housing. And in doing that, they've identified houses which I'm sure everybody will be familiar with the sort of infrared pictures of the house where the heat is escaping through the roof and the window. So they've done vertical photography to do that as a pilot. And what that data shown is that some houses, during a period that we would expect people to have their heating on, some houses are dark, where we'd expect them to have some level of redness to show there is some heat loss. Now that's either they're dark either because the house is empty, the insulation is excellent, or there's somebody in there that hasn't got the heating on. Now, with everybody's permission, if we have that, the person's permission, if we know that we have a person there and we know that they've got, we know which age group they're in, and then if we cross-reference with their medical data, we could potentially say we've got there's a potential issue with an individual, which says that they're a frail elderly person which is under constant medical support. They're also getting some social care support, but they don't seem to have their heating on at a time where people would have the heating on because the outside temperature would warrant, typically people would have their heating on. What we might like to do then is to go to a voluntary community responder who knows this person and say, well, could you pop by and talk to just go and do a neighbourly visit and see if they're okay. Now, we'd never be able to do that using the separate services that we all run unless somebody triggered it by saying, I've got a problem and I've not turned up for an appointment, which I was supposed to, and nobody can track the person down, or you haven't met somebody, or you haven't, anyway, all of those things. So I think the first part of that is the relatedness of all the different types of information. Some of it will be quantitative, as I've outlined, and some will be qualitative, which is, we haven't noticed some people being around for a while. You don't actually measure those things, but you can capture that as almost as free text. We've certainly got the skills in Dorset already, but also an expanding network of skills, which would allow us to look at that intelligence and make sense of it. And one of the other presentations you'll see during this festival is on the Dorset Intelligence and Informatic Service, which now allows us to bring together those people who might be vulnerable just from a medical point of view currently, to say, actually, these people need extra support, which they might not be asking for, and we should offer it. And these other people, actually, they need help around prevention, but they probably won't want to come to see us to get that because they don't want to bother the GP or equivalent. So we might be able to find a different way through a social media channel or through something else to provide that kind of support. So I think that's the first part, which is around the relatedness of data for me. So I think it's absolutely in scope with the Living Lab. The bit which is about how you measure benefits is hard, and all of us involved in delivering services of one form or another find it hard to say, well, what was the absolute benefit? Because in the main, the benefit needs to be defined by the person receiving the service or the support or the intervention or the integration. But we typically tend to define the benefits based on the professional's view of the world. So that, the clinical teams will say, well, the outcome for that person was they've lived longer. But that person, maybe we might be back to John's ethical question. The person might say, well, actually, I would like to live less, but being happier. So I think one of our bigger opportunities is to start to really holistically look at people and say, well, what matters to you? What's important to you? And we become much more a partner in people's living their lives rather than we become well, when it all breaks, come to us and we'll fix it and we'll patch you up and we'll send you back out, because that might not be what anybody wants. And the other bit, sorry, it's a long answer, John. Sorry, but the other bit which ties into that is in primary care, we estimate that 30% of primary care presentations, so people coming to visit the GP or phone the GP, is less to do with their absolute medical health and more to do with their life and how they're living their life. And GPs provide an absolutely fantastic service looking at people in the round. And I think if we had that looking at people in the round and saying, well, how do we put wrappers around to help, but not smother? I think that is really key. And I think that I think the benefits, we need to build the benefits on that basis. But we've got loads of things to measure that we can do now. So how long, what's the average lifespan we measure, and in some parts of our county there's a 10-year difference. Well, that can't be right, can it? No. And if we look at certain communities, some access services and some don't, and that can't be right either. And if we look at some ethnicities, there's a high propensity for some to access services and some not to. And then there's if you look at inequalities across the patch, there's a wide range. And then if you have a look at how we deliver services, our assessment across the different service providers said there's also variation between what some do versus some others do, and what our role is in broader as a CCG, but also I think through the Living Lab, is to say how can we make sure everybody gets the same opportunity to have the same level of service. And I think the research can help us if we start looking at things collectively. It gives us that intelligent view.
Thank you, Phil. That's been fascinating. We've got another question from Brian, but I think perhaps Phil and I could catch up with Brian outside of this because we're in the same network. So thank you very much to Phil. Thank you very much to the attendees. I hope it's been really good. Really special thanks to Brian for stepping in and taking control when I was stuck in another session. If you've enjoyed the session, there's loads more coming up. Phil mentioned the DICE, the Dorset Information and Insight Service. I think I almost got it right. And that's in about 15 minutes or so. But Matt and Aidan are around tomorrow talking about the highlights of today. There's the digital newsletter. Don't forget to share your experiences on social media using #Futurefest. Thanks very much again, Phil.
You're welcome. Thanks, everyone.
Thanks, everybody.
Thanks for watching.